and to discuss with you the different options which we do have for the tricuspid regurgitation. And as you heard, we're going to discuss also a live in the box case, and I'm going to present or start this video, which is the patient presentation of the patient which we treated.
I'm very glad to present you our case today. We have an 88-year-old female patient, and she suffers from dyspnea exertion. Currently, she's New York Heart Class 3, and she had multiple hospitalizations due to heart failure when she was transferred to our center, and we identified in our exam that she has a right-sided heart failure, and her symptoms are due to severe tricuspid regurgitation. Regarding her comorbidities, she has atrial fibrillation, and we observed a preserved renal function with a GFR just under 60, and she had a few weeks ago she had a stroke in February this year, and she has still persistent paresis of the left arm. We calculated a tri-score of 4 points, predicting 8% in-hospital mortality for isolated tricuspid surgery. We performed the right heart cath last week, and we could exclude pulmonary hypertension. We observed PA mean pressure of 21 and only mild elevated wedge pressure of 60 millimeters of mercury, and cardiac output was within normal range. On the right side, you see the patient's medication. She takes a beta blocker. Unfortunately, she doesn't tolerate ACE inhibitors or ARB because of low blood pressure situation. So we had to focus on diuretic therapy. She has a loop diuretic, spironolactone, and tridines. She also takes apixaban for her atrial fibrillation. In the coronary angiogram, we could exclude significant coronary artery disease. We observed only mild narrowing of the medial LAD, and right coronary was okay, so nothing to intervene. When we did the echocardiogram, TTE, on the left side you can appreciate the left ventricular function, systolic function is normal. And mitral valve was also within normal, only mild regurgitation of the mitral valve. When we were focusing on the right ventricle, we see this massive dilatation of the right ventricle, and systolic function of the RV was still preserved, but we then also appreciated this severe tricuspid regurgitation, which we graded 4 out of 5 grades, and we see the TE exam just in a few minutes during the procedure.
So this is the patient presentation.
Jörg, that's fantastic. Thank you very much. I learned something. You can go up and show a film, so you don't need to say anything.
But that's the beauty, huh?
So now we will ask you a question. And I forgot something very important. Mauricio Taramasso is answering your question as well, so he's our chat master. So don't hesitate really to ask questions. And in the room, you can stand up. There are microphones everywhere, and we will be able and keen to answer your question at any time. So you presented the patient, 88-year-old female, very severe tricuspid regurgitation, atrial fibrillation. The right ventricular function is quite good. So my question, what is in your eye the etiology of tricuspid regurgitation in this patient? Or what was your interpretation of all these findings?
I think, excuse me, you probably can still appreciate here on this image that the right ventricle is dilated, but we have a huge dilatation of the right atrium. We have atrial fibrillation, and probably what you have seen is that also the tricuspid leaflets are not too severely tethered. So this is a situation where we probably have more like an atrial functional TR, probably due to the long-standing atrial fibrillation.
Okay. And maybe we can ask Didier, but I will ask you first. You have seen the anatomy of the patient. What would be your guess or your strategy in that patient as a treatment option?
So what I like with this patient is the fact that first it's a high-risk patient, and so that patient deserves something, a treatment. The RV function is not severely impaired, so the potential benefit in terms of intervention seems obvious for this lady. So I would consider for this particular patient, as it is standard of care now, to start with the evaluation of the feasibility of an edge-to-edge repair first, and if the patient was not suitable for this type of therapy, it would have been considered for a TTVR, a valve replacement. So, but first, I would say that this patient seems suitable for an edge-to-edge repair.
Volker, what is your opinion? So we have also option available, a cardioband. Would that be an option? You have a lot of experience.
Yeah, I mean, I would definitely say yes, but I agree that first of all we would evaluate for edge-to-edge, particularly given the age and the simplicity, potential simplicity of the procedure, and therefore I would agree. But I mean, cardioband could be an option given that, as Jörg said, there's no tethering, and this is really a good predictor to have a good outcome for cardioband as well.
Edith?
Yeah, I totally agree. I mean, the kidney function is okay, so I definitely would also think about like a cardioband option. But of course, 88 years, really sick patient, you would reduce the time of the procedure, and I would also definitely go for edge-to-edge. Also that the medication is, so it's all around, and yeah, surgery is out, so definitely.
And if replacement would be available, you would... What would your guess, Philippe? Could that be an option?
Yes, I mean, we would have to look a little bit closer on annular dimensions, do a CT, do a bit more planning. Obviously, it requires more planning than going forward with edge-to-edge. But looking at it, it seems to be within a range where replacement could be an option, yes. But having said that, I mean, this is I totally agree, this is atrial functional TR, and this is such a good substrate for edge-to-edge. I mean, these patients, they almost always benefit. Yeah, I'm looking forward.
May I ask you, Jörg, about, you have a huge experience, first in terms of evaluating these very complex patients, and you just elaborated a bit on the utility of the TriScore. Could you provide us with more insight? How do you utilize it? Is it a useful tool to select the appropriate patients in your experience?
To be honest, no.
Yeah, honestly.
Absolutely no.
Always.
No, because the patients which we are in more than 98% evaluating are patients who are in these late 70s, 80s, or even late 80s, who are really no candidates for a surgical option. We do know that patients who are being considered eligible for a surgical procedure still have a mortality rate somewhere around 8 to 10%. So these patients, where they even have kidney function, liver dysfunction, there are no candidates for any surgical procedures. So I don't think that we really need to evaluate such scores. They are not helpful for us right now. We would love to have some scoring systems incorporating all the results which we're just gathering to understand better what are the outcomes of an interventional procedure in such patients concerning not the early safety or because we know that all our procedures are very safe, but considering what kind of patient is really having a good profit, let's say after 1 year. That would be much more interesting. So,
Jörg, the majority is seems to be for edge-to-edge repair in that patient. Can you share with us maybe your experience with edge-to-edge repair? So I'm going to stay here and continue with the next presentation.
Absolutely. Okay. I was asked also to summarize a little bit what kind of options do we have on the edge-to-edge repair and what kind of results. So you know that we do have this PASCAL system which we're using on the mitral side for quite some time now, and we can also have it CE marked for the use on the tricuspid side. Here is the catheter system being shown. You have a guiding catheter, a steerable catheter, and an implant catheter. And we do have 2 implant sizes, the regular PASCAL device with a width of around 10 millimeters and the PASCAL ACE system with a width of 6 millimeters. And they are nitinol based, so they're a little bit flexible and have a very nice distribution of the pulling forces onto the leaflets. And we can use those both devices very safely and elegantly in the tricuspid field. And we started about a year ago to collect data from all other, or for some other European sites, to get their learning experience with the PASCAL system in the tricuspid field. So we started this registry, which we call PASTE registry, the PASCAL for tricuspid regurgitation, a European registry. And this is a large investigator-initiated registry looking at the safety, but also on the efficacy of the PASCAL system in the really real-world practice. Here are the sites being shown, many sites in Germany, but also some in Switzerland, Stockholm, and Great Britain. It's still a retrospective study, but we also want to go now a little bit more prospective, because at the end of what you're going to see down here, we are targeting a size of approximately 1,000 patients so that we can really dive also into a little bit of subgroup analysis. The difference compared to other registries, investigator-initiated registries, is that we have an echocardiographic core lab, or at least a centralized echocardiographic analysis in the same form, so that we can a little bit say something also about the results. So I'm presenting today for the first time the results of the first 500 patients which we included. And you see here the demographics of those patients, almost 80 years old, around 50% are female, high risk scores with a score of almost 7%. And you see a lot of comorbidities, 92% atrial fibrillation, about 1/3 had a lead, renal failure with the GFR below 60, also very present at 80%. The analysis of the echocardiographic data is currently available for 370 of those patients. And you see that we're treating around 40% really with massive or torrential tricuspid regurgitation, mainly a functional secondary etiology with an estimated systolic pulmonary artery pressure around 40. Technical success is very high in these procedures. Although we have these large gaps sometimes in these patients, 99% with an average device use of 1.8. What you see in the meantime, we are having 2/3 of patients being treated with the ACE system, procedural time around 2 hours, and then a very low SLDA rate confirmed by the echo analysis of 2.7%. So right now, when we look at the latest patients, more or less 93% are being treated with the ACE system, the smaller implant as you have seen before. Now, what can we achieve? You see here the TR grade in the 5 grading scale with torrential, massive, and severe TR. And you see that there is a high ratio of those very severe TR grades. This can be reduced very effectively. More than 80% at discharge had a TR of 2+ or less. And this great result is being maintained at follow-up. Right now, we're looking at echocardiographic follow-up, a median of around 6 months, 81% having these good TR reductions. Looking at the data from the mortality and need for repeat hospitalizations, these are sick patients, so the rate is relatively high. We're still, as you see in the numbers down there, we're still in the process of really getting the follow-up of the majority of patients. This is an ongoing process, but still we're gathering these 1-year outcomes in this large patient group. What about the symptoms? Because this is the most important aspect for the patients which we're treating. We see that about 2/3, and this is consistent with all the other registries and trials, At follow-up, 2/3 of these patients are being in New York Heart Class 2 or 1, although the vast majority, 90%, were in Class 3 or 4 before the procedure. Improvement in 6-minute walk test, decrease in body weight, which is being reported about 5 kilograms, which I think is pretty substantial and impressive. And we also see a little bit of significant drop in the pro-BNP. So just concluding this a little bit, as you see, with the edge-to-edge repair technology as one of the 3 options which we can use, that this PACE registry demonstrates as an investigator-initiated registry today the results, what we can achieve, that the PASCAL ACE system has a very high technical success rate and also procedural safety, although I haven't shown in detail all the 30-day outcome data, I have to admit. Efficient TR reduction, I think we were able to show in this echocardiographic analysis is sustained at 6-month follow-up. And this improvement in TR is associated with a significant clinical and echocardiographic improvement. Of course, these are just registries, and we need to have prospective randomized clinical trials, and these are underway to compare leaflet repair with medical therapy to really show the advantage of this kind of therapy. Thank you very much.